So next we will be learning about what are the indications of the endotracheal tube, the techniques of insertion of the endotracheal tube, what are the techniques to find out the correct placement of the endotracheal tube, the complications which are associated with the intubation process, and in brief about certain special tubes. Okay, so first we'll tell about what are the indications of endotracheal tube. That is, endotracheal tube intubation, this process itself can be divided whether there is any elective intubations or emergency. Elective indications which includes like surgeries in a full stomach patient, or patients requiring positive pressure ventilation, or patients who are having surgery in positions other than supine, that is lateral or prone, etc., or patients who are having surgery in the nose, and all these things will be for endotracheal tube intubation, especially the oral intubation most commonly done. And indications where only specifically nasal intubation will be required is some head and neck surgeries, or surgeries which are involving temporomandibular joint or mandible, etc. So these are some indications for nasal intubations, but in these are elective indications. Now, what are the emergency where we have to intubate as patient in CPR, or patients who are gasping, patients who are unable to maintain their airway, or in case of any tracheobronchial toileting is required, in that cases emergency intubations are done. Okay, what are the so we finished about what are the indications of endotracheal tube intubation. Now coming to what are the various techniques which are seen. The techniques of this in intubation, basically we have oral intubation techniques, and then we have the nasal intubation techniques. Whenever we are doing the oral intubation, we will place starts with the positioning of the patient. Okay, the positioning of the patient, it is called as the sniffing position, or the morning air position, or also called as Chevalier Jackson position. Okay, so in this position, there is extension at the atlanto-occipital joint and flexion at the atlanto-axial joint. So in obese patients, we mainly see that the sternum to the external auditory canal comes up to be in a straight line when they are lying down. So this is the positioning, how it's done. In case of an oral intubation, usually we use a laryngoscope to push the tongue or swipe the tongue from right side of the mouth to the left, visualize the cords and do the endotracheal tube intubation. Okay, and whenever we will see that in case of an endotracheal tube intubation, we are doing orally, the disadvantage is that it may cause damage to the oral structures. It may also cause biting of the tube when the patient comes out. So in this case, bite blocks are placed. And another is that any oral intubation is not sustained well by a spontaneously breathing or awake patient compared to the nasal intubation. When we are doing a nasal intubation, the technique lies in that first of all, we have to select the nostril which is a wider one without any septum or without any deviated septum, that is the side to which deviation is present. And we should also ensure that we put vasoconstrictors prior, lubricate the passage well in order to reduce any trauma to the nasal structures when we are passing this nasal intubation. So whenever we are doing a nasal intubation, we can gradually use these nasal airways to dilate it so that we have an assessment of which size tube to be passed. When we use or observe in general that the nasal tubes are, which we use in nasal intubation, are generally smaller than that of this oral tubes. Another thing is that when we pass it through the passage, we can extend, we can just push up the tip, pass it till it reaches the posterior pharyngeal wall. Later on, we can put a laryngoscope and guide the nasal tube using a Magill's forceps. So both this nasal or oral intubation in the olden times were done by using blind techniques. In a blind technique where such apparatus is not available, oral intubation is generally quite difficult. We have to do manually by pushing the tongue and the oral structures, and the tube is usually guided blindly. And nasal intubation usually can be done where we position the patient with a full extension, lubricate the passage well, pass in a spontaneously breathing patient with adequate airway blocks, the nasal tube, and we can give a cricoid pressure to guide the endotracheal tube into this larynx. Usually, a successful intubation in such blind techniques is guided by the moisture or can be guided by the EtCO2 tracings after intubating the patient, right? Next, we have the technique of the correct placement of this endotracheal tubes. The correct placement of the endotracheal tube we can classify or we can find out by using clinical, okay, they can be found out clinically or by using, so first is the clinical examinations, that where we will find out that we are in place or we have certain equipments which will help us to find out that we have placed the endotracheal tube correctly. The correct placement clinically can be found out by direct, that is under vision, putting of the tube across this cords. Second thing which we will observe is that moisture we will see in case of a tube, that is from the exhaled gases of the patient. Third is whenever the tube passes across the cords, when we palpate it, we will be able to find out that the tube is in the trachea. Fourth is bilateral chest movements. We have 5-point auscultation which has to be done after an endotracheal tube intubation for the upper lobes, for the lower lobes, and the fundic point which is present. Okay, and also we have to ensure bilateral air entry is equal in both the lungs. Another is on epigastric distension. So this is one sign that we have passed the tube into the esophagus instead of the trachea. When we give 2-3 breaths, we see that the epigastric distension may be seen. So this is one of the signs that it was an esophageal intubation. Then what are the equipments which will help us to identify or confirm the positioning of this endotracheal tube? First comes as the pulse oximeter. But the pulse oximeter takes a much longer time because the patient to desaturate if adequate pre-oxygenation has been done. So about 5 to 8 minutes we will not be realizing that it was an endoesophageal instead of endotracheal intubation. Next is using capnometer. Capnometer or the EtCO2 graph is one more device which will help us to identify that we are in the endotracheal intubation. But in certain scenarios like cardiac arrest or in case of bronchospasm, this was not a very good guide because still we will not be able to know whether we have done an esophageal intubation or not. Third is a chest X-ray. Chest X-ray help us to identify the correct placement, also the position of the endotracheal tube. Usually we have what is that 3-5-7 rule, that is in centimeters, where the tip of this ET tube must be present from the carina in a flexion. Okay, this is in a flexion, this is in neutral, and this is in extension patients. Okay, extension of the neck. This will be the position of the endotracheal tube tip from the carina. Another is the fiberscope or fiber optic bronchoscope, which will help us to visualize. If we go through this tube, we'll be able to see the trachea with the bronchi and bronchioles, but this will not be there in case of an esophageal intubation. Another thing is we have what is called as colorimetric EtCO2 detector. We would have seen mostly used in casualties. These are all color coded. Okay. So whenever we connect the endotracheal tube to this detector, there will be a color change. The color change is actually from the blue to green and then to yellow based on the EtCO2 concentration. So this is one of the confirmatory signs that we are in the trachea. right? We see is in the pressure volume loops. The pressure volume loops will not come if it is an if it is an esophageal intubation, but it will be present in case of an endotracheal intubation. And also in EtCO2, we see that certain different waveforms will be present if it is an endobronchial intubation. One of the latest equipment which will help us in differentiating if it is an esophageal intubation or not is using an ultrasound. So we will now be discussing regarding some special types of this endotracheal tube, briefly about certain salient features of each of these tubes. So first is Cole's tube. Cole's tube is basically used for neonatal resuscitation. Looks somewhat like this. Okay, it's consisting of a narrow end. This portion is the portion which will be the internal diameter of this tube, whatever is used. And the proximal portion that is present is quite thicker. Okay, so the proximal portion will be quite thicker. There is a shoulder, and this is the patient, that is the patient end, which will be uniform. That will be the internal diameter of this tube. This one is an uncuffed tube, and this shoulder that is present on the bend, which will prevent the further insertion inwards. Okay, and this is actually used for neonatal resuscitation. This preformed tube that is present, it cannot be pushed downwards. If we try to further push inwards, it will cause lot of trauma. So this is one of the salient features of the Cole's tube. Next is we have the micro cuff tube. The micro cuff tube is also basically designed for the pediatric age group itself. So as we see, the salient feature in a micro cuff tube is that the cuff that is present is quite small, and these cuff which is present, they have low volume. So whenever we try to distend it with a proper pressure monitoring, it will not cause much trauma to the structures, to the trachea of the pediatric age group. Another thing is that in this micro cuff tube, there is no Murphy's eye. Okay, there is no Murphy's eye, and we see because of this feature, the cuff is present more distal in the tube compared to that of what a normal tube will have. Okay, this is called as micro cuff tube. Okay, another tube which we encounter in case of any laryngeal surgeries or any biopsy of the laryngeal tumors or any short procedures is the microlaryngeal tube. The microlaryngeal tube basically will be available in the sizes of 4, 5 and 6 millimeter of internal diameters. They are very thin tubes if you would have observed, and the cuff are quite elongated. They help to provide a surgical space for this laryngeal surgeries. The disadvantage is that these tubes are so thin that the time required for expiration sometimes may be insufficient. So they may take a longer period for expiration, and because these are very thin, sometimes they may require maggots for guiding it through the vocal cords during the time of intubation. Right? Next, another type of special tube is the ring adder Elvin tube, which is also called as REE tubes. Okay, these are the preformed tubes which we see. Okay, they may be oral or south pole tubes. Okay, or nasal or north pole tubes. So these are the two types of the ring adder Elvin tubes. The oral or south pole tube, we see that it is bent in a way that, so we are intubating here. This is the mouth of the patient. They would have slept like this. This is the mouth. So they are preformed in such a way that there is a marking at the level for the placement. So the length which will be getting inserted into the patient is quite fixed. Okay, and this junction comes at the point, and the tube, the remaining portion of the RE tube is falling over the chin, and the circuit falls over the chest of the patient. So this is the South Pole tube or the oral ring adder L1 tube. So this is very useful in case of any oral surgeries or in case of cleft lip palate surgeries where we also want it away from the surgical field. But the disadvantage is that the length of the tube which is there always inserted is quite constant. So this may go too much in for certain patients or it may be too much out in certain patients. These are available in both cuffed and uncuffed variant. Similar is the North Pole tube that is present. So in case of a North Pole, it is inserted in the nose of the patient. So this goes inside, right? And it comes out like this. So this is the mouth of the patient. So this is the North Pole, right? So this is very useful in case of if you want to keep away and there is some surgery in the oral cavity, you can use a North Pole tubes. Here also the same problem arises that the length that goes inside is quite fixed and therefore it may vary for different patients and may go endobronchial for certain patients. Also, because these are curved tubes, they provide increased resistance to the gas flows and also very difficult to suction through these tubes. It's not possible to suction through the tube because these are not straight tubes. Next, we'll be seeing the flexometallic tubes. The flexometallic tubes that are present, they consist of something like a metallic or nylon spiral, right? Metal spiral that will be there passing throughout the length of this tube. These flexometallic tubes which are present, usually they come in a standard size of 30 centimeter, okay? And they're available in usually sizes more than 5. And flexometallic tubes which are present, often this will help them, the metal spring basically helps it to keep the tube away from the surgical field. So these are very commonly used in the head and neck surgeries. Also, because of the presence of this nylon spring, the flexometallic tubes cannot be cut. And one more thing is that these flexometallic tubes, because of their flexible action, are more prone for accidental extubation. Another thing is that they pass easily through any of the fiber scopes. So these flexometallic are of great importance in nowadays because they have because these are straighter tubes and they also help in keeping the tubes away from the surgical field. Coming to next is the Oxford tube. These are like made up of red rubber. They are like in a 90-degree direction. These Oxford tubes were used in the olden times where the proximal portion was bit thinner, that is towards the patient end was quite thinner, and the distal end that is present is thicker in diameter. That is because these were made up of rubber, there were increased chances of latex allergies. Also, they could be reused and cleaned and washed, and they could be reused. They were used because of their fixed length. They were also more prone for endobronchial intubations or accidental extubations. Next, coming to electromyogram tube, these basically contains like electrical cords or the wires that are present within the tube, and these wires will be attached to a monitor that will be monitoring the action of the nerves. Specifically, these electromyogram tubes are used for thyroid surgeries for nerve preservation. Next is this intubating LMA tube. The intubating LMA tube is basic purpose to be able to intubate through a standard LMA. These are made up of silicone. They are wide reinforced. They are having short bevel with a Murphy size. And these cuffs which are contained in this intubating LMA is usually a low volume, high pressure cuff. So, purpose of this intubating LMA is to be able to pass through the supraglottic airway device. So, next we'll be discussing about the laser resistant tubes. Some of the common types are there are 4-5 types of the laser resistant tubes. We will know brief features of each of this. Okay. In the laser tubes, we have laser resistant tubes, we have laser shield tubes. Okay, then we have Norton tubes, right? Number 3 is laser flex tube, laser tubes. Okay, laser shield tube is basically made up of silicon that is coated with an aluminium wrap. That is, we wrap this tube that is present with an aluminium foil, and that in turn is again wrapped with a Teflon foil. The cuff of this, but we have the cuff of the tube that is not protected by the laser, and the portion of the tube just below the cuff is also not. So the cuff contains methylene blue crystals. Okay, so it contains methylene blue crystals. We inflate this cuff with water or normal saline. So and also we can keep like a cottonoid pledget around this tube and soak it with normal saline before insertion. So this provides protection against carbon dioxide and KTP lasers. Another type of the tube is the Norton tube. The Norton tube is made up of especially like a metal with an external rough appearance. It doesn't have any curve or doesn't have any Murphy's eye. Because of its rough appearance and metal it is made up of, it causes lot of tracheal damage. Next is we have the laser flex tube. The laser flex tube is made up of stainless steel. Okay, it also has like a stainless steel body with a rugged appearance and a cuff that is inflated with methylene blue crystals that contains methylene blue crystals, and we inflate it with water or normal saline, right? Laser tubes is something that is made up of like a white rubber. Okay, so the laser tubes is like made up of white rubber. Special feature of this, it has a cuff in cuff appearance. Okay, so there is two cuffs, there is two inflation systems with two pilot balloons. Okay, this is the laser tubes. It is made up of like white rubber. We have to wrap it with aluminium foil and micro seal sponge. Okay, the inner cuff will be inflated with air and outer cuff is inflated with water. Okay, so there are two cuffs with two inflation systems. So if the outer cuff gets damaged because of the laser, the inner cuff still will be keeping the lumen intact with its contact. Okay, and we wrap it with aluminium foil, and then we have micro seal sponge. It is dipped in the normal saline before using. So we have now discussed we have come to the end of this video, and we have discussed about this what is an endotracheal tube, its indications, what is the techniques, what are the parts in detail, and some basic features of this special size tube. I hope this video was useful for all of you. I'll see you all in the next video.